legs that come post-op should be relatively warm and have cap refill. Otherwise, unless the surgery was unsuccessful, but you know, it doesn't really happen to me. And the vascular exam, that's your pulse exam. Like, oh, I got both signals real easy, or you know, I got the posterior tib, I couldn't find the dorsalis pedis, and that's your baseline for the night or for the shift. This is probably your best friend when it comes to your peripheral arterial disease post-op patient, because some nurses, and I'm guilty of this too, and Jessie will say that, she says, I could find a pulse on a piece of plastic. I'm like, oh yeah, I think I feel it. But so it's a very, an objective thing is to get a Doppler signal, because you can actually hear the machine give you a signal, as opposed to feel it, and wow, I'm getting a third cup of coffee, so maybe that's my fingertip. So, so this is a very helpful thing, because you can't really fudge this. I mean, you either hear it or you don't. These Dopplers we have on the floor are, even though they look like they're from the 1950s, they're actually the most reliable. These Dopplers are very cheap, and they're not very good. And these are the best, but they're also very expensive, so we don't have any. How does a Doppler work? And this is just very brief. So the way a Doppler works is, it's called the Doppler effect. So you remember the Doppler effect from, if you're listening to a train, as it comes towards you, the closer and closer it gets you, it has a higher pitched sound, and then when it passes you, it has a different sound. So that's called the Doppler effect, and it's based on the observer. So a transducer for a Doppler probe submits a frequency, and the frequency that's sent back to the probe depends on the velocity of these blood cells. So if you put it right over the artery, the frequency is set, it reflects off the red blood cells, and depending on how fast the red blood cells are moving, will determine what this return frequency is. The bigger the difference between the observer or the emitted frequency and the return frequency gives you how great a sound you see, whether you hear a robust sound or a weak, or you hear like, that's determined by how fast and how much flow is happening in your vessel, if your dorsalis pedis. And that difference in frequency gives you your Doppler shift, and gives you the intensity of the sound you hear on your probe. So yeah, I will just go over that. So these are the two vessels that we assess with our post-op PAD patients. The posterior tibial is assessed on the medial aspect, the inside of the foot, right behind the ankle. So about a finger breadth behind the ankle, you put the probe and you can kind of fish around. That's where you find your posterior tibial. And the dorsalis pedis is right over the hamate bone of the dorsum of the foot. And that, the easiest way to find that is to say, let me look for a big vein, because usually the artery runs alongside the vein. So if you can find a vein, then that helps you. Same with the posterior tibial. If you see like a vein in that area, you might find the artery. The reason is when you evolve or when you develop an embryo, they grow together. They develop. You grow out your limbs. They grow out the nerve and the artery and the vein all grow together. So that's why you have that neurovascular bundle. So that's an easy. Also, light pressure. Some of these patients have very small, finicky arteries. So if you could even actually occlude the vessel with the probe. Put the probe down, you can actually occlude. So try very light pressure, and use a lot of gel. This is based on acoustic or sound waves, and sound waves don't travel well in air. So the more gel that you have in between, a nice coat of gel, will transmit a better signal. These are the Doppler thing. You can see just takes a little time to futz with. You can try it on yourself, or try it on a patient that is a carotid patient that probably doesn't have PAD, but hey, look, he has the risk factors. Let me see if I can get his signals and see what they are. Because you have so much time to just futz around, right? Between your 5 patients. So what surgeries to expect? So I looked at our database and see what's the most common surgery that we perform for lower extremity PAD. FemPop bypass is probably the most common, followed by femoral endarterectomy with iliac stents or SFA stents. And that's a combination, that's a hybrid procedure. It includes open surgery as well as an endovascular intervention stents. From the cath lab, it's all endovascular. It's all sheets. There's no incisions. There's no wounds. So we don't have the capability of doing wounds, doing open surgery in the cath lab. So they're all sheets and catheters, and they're all percutaneously based. So that's all going to just be stents and balloon angioplasties. These patients won't have anesthesia. They won't be put to sleep. Those patients are generally a little easier to manage, and because just the nature of endovascular surgery, endovascular surgeons are less invasive. They're not big incisions. There's not general anesthesia. So if you give someone an endovascular intervention and solve their problem, it's probably a better option than the open surgery. And that's just coming from a surgeon. So there's some truth to that. I know if I needed, or my father needed an intervention, and you could, instead of a bypass, I could give him a stent in his SFA. So long as it's in a good spot, I would try the stent first. That's kind of what we do in our practice as well. So reasons for intervention, so part of your sign out, part of assessing your patient is, okay, what are we talking about here? Are we talking about he has a necrotic black crusted toe, and that's why he got his operation because his foot's died? Or are we talking about someone who can't really walk more than 200 feet, otherwise his foot looks normal, otherwise he's okay, but he's really not walking well? So that's a different, less severe version of this. The most severe version is when the patient has critical limb ischemia, tissue loss, necrosis of the toes. Those patients require more extensive operation. They're generally sicker from their other cardiovascular disease because their arteries have gotten so bad, their legs, and God knows what's going on with their coronary arteries, their carotids. They're older. Most of them have diabetes, and there's also one-offs. We have these emergent interventions for hemorrhage. A lot of patients, either from the cath lab or from IR, will have their groin expanding hematomas, and they just require an urgent cut down and repair. Those patients usually don't have significant peripheral arterial disease. They may or may not, but usually it's a technical issue that happens with the interventionalist that causes the problem, and that's easier to fix. You cut down, you kind of fix the injury that's caused. But that's part of the process of assessing your patient, knowing why they're there. Have anybody taken care of a post-op like emergent intervention hemorrhage patient, like from IR or from cardiac? Those patients, once the problem's fixed, it's usually smooth sailing. They have a big wound, they have a lot of pain, and they have probably maybe a drain in place. But the critical limbs patients are probably the most challenging because they're the ones who come with the most comorbidities, and they've gotten to the point where they're not even supporting viability of the tissue in their foot. Usually their health is, their other comorbidities are prevalent. So I do have some cases. Before I start the cases, anybody have any questions about the post-op assessment? Oh, there was something else I wanted to show. Doppler. I didn't make one of my slides. But one of my slides is when you receive a patient, you should do a PAWS assessment, P-A-W-S. And came up with this because you're dealing with someone's leg, it's their paw. But PAWS assessment is P is your physical exam, your pulse exam. That's the most important thing you got to know when you get the patient. W is the wound. What wounds are you dealing with? S is the systemic illness, like what other things are active with this patient. And what was the anticoagulation? So P is physical exam, pulse exam, P. A, what's the anticoagulation? What are we doing for that? W, where are the wounds? Are there wounds? If it's just a puncture, it's just a puncture from the cath lab. And S, the systemic illness, what else is going on with the patient? So your PAWS assessment, when you get a sign out, or you give someone a sign out when you go break, or you get a new patient, that's kind of an important piece. Knowing where the wounds are, what do they look like? Is there a hematoma? Is there not a hematoma? Is there a vac in place? Is the vac working? Is the vac over closed skin, or is the wound open? We went over the pulse exam. That's something that you should keep as your baseline. Whenever you get a sign out, whatever you get from your doc or the nurse or the PA, that's your baseline. If that changes from your shift, then that's something you need to let somebody know about. The systemic illness stuff is not unlike any of your other patients. If they're high risk for coronary disease, you want to make sure they're not having chest pain, make sure their beta blocker was restarted. If they're daily aspirin, hey, like I start the aspirin. Did they get aspirin in the packet? Anticoagulation. Oh, it is here. Oh, good. I thought I forgot it. Anticoagulation is a big thing. You have a patient who comes in with, on aspirin Plavix for their coronary stents, and I do some peripheral disease. Very rarely will I say, oh, you got to hold the Plavix and the aspirin, because I mean you can live without your leg, but if one of your coronary stents gets occluded or gets compromised, then it's a much bigger problem. And I always continue with our aspirin and our Plavix. So you need to get that information. I always give patients 325 aspirated PACU when I do EVARs, carotids, peripherals. I feel like the acute phase of the insult to the tissue promotes more platelet aggregation. So a 325, a nice robust aspirin, I do that almost for everybody who goes on to the PACU. But you need to know that too. And I also have the patients who are chronic AFib. They stop the oral anticoagulation and they start a heparin drip. When can I start that? That's like gotta be one of your questions. All right, when is this getting started? And also, a lot of patients who get stents from the cath lab will get a new onset Plavix. So, a lot of patients will ask you, what is this new medication, and why do I have to take it? And anybody know what the mechanism of Plavix is?
The antiplatelet?
Yeah, it's an antiplatelet, right? And it works on P2Y12. Yep, you know that assay that they look to see how effective it is. And aspirin works on the COX-2 inhibitor, or the COX-2 enzyme in the platelets. But either way, they both work on the platelets to make them not work. So you can just say, I tell my patients, it's like an aspirin. It works on the platelets differently than aspirin does, but both in combination really make your platelets not sticky. So that's what I basically tell the patients. And it's important when you have a stent because the first response for the blood vessels, like you saw in that first slide, is depositing platelets. So whenever you have an injury, whether it's a clamp injury or whether it's a trauma, platelets deposit. So having them not as sticky is very helpful in making sure that your stent doesn't acutely go down. And I put patients on Plavix for SFA stents for almost a year, and then after a year, if they quit smoking and their stent looks good, then I'm like, okay, maybe we can take the Plavix off for their SFA stents. I'm sure the cardiologists have different criteria for their coronaries. So they probably keep their patients lifelong, if not, at least a year. All right, so let's do a case. And who wants to get picked on? Somebody new. Who's been less than you guys? I've seen you guys way too much. You guys are,
They're all new. All the four of them and these guys. They're all new. Except Cal.
So you have an 82-year-old, you're starting your morning shift. You have an 82-year-old female with coronary disease, a remote history of right coronary stenting. She underwent an elective right femoral to above knee popliteal artery bypass with biological conduit. I often use in our practice either cryovein or bovine carotid artery. And I also, the sign out is you got a completion angiogram. So what's your pause assessment of this patient? Okay. The night nurse or the day nurse or whoever's giving you the information on the patient, the PACU nurse, says the patient has a palpable dorsalis pedis, biphasic posterior tibial on Doppler, neuro intact, sensory is intact. Just got a 325 aspirin in the PACU. Wounds has a groin wound with a Peeran in it. Other wound has a Mepilex. So where's the other wound on the leg? Reading this information.
Inner thigh.
Yeah, you guys are.
Oh yeah, we're not supposed to tell you. Sorry.
It's above the knee on the inner aspect. So fem to above knee popliteal artery bypass is above the knee, and everything's on the inside. So your other wound is here. You don't have to worry about the lateral aspect because you can't really assess the vessels. You can't access the vessels or expose them surgically from the lateral aspect. Okay, so you start your assessment. You're working the patient up. So you do your pause assessment. You know your exam. One of the things, your PA makes his rounds and they're talking to you, or they're making their night rounds and they're talking to you. What's our plan for the 325 aspirin? You know, they'll tell you, yeah, we're gonna do a full dose aspirin because Dr. Peeran's worried about the soft atheromatous debris and thinks that this guy would benefit from 325 aspirin. And you say, okay, so we'll start that in the morning. You just got one in PACU. How often do you guys, when you have a fresh post-op, Amy, how often should they check the wound in the course of a 12-hour shift? Like 3 times?
If they come out, it's every 15 for an hour, then every half hour, then every hour, then every 2 hours.
Okay. So you're looking at the wounds a lot. So you'll have an idea. And Provinas are vac sponges. They're like KCI vacs, and they suck down the groin, so you really can't see the skin. All you see is this purple thing. So it's easy. It's probably best to palpate on either side of it to see how soft the tissue is. And like, oh, that feels nice and soft. Don't hurt the patient. We'll tell them, okay, I'm going to push. It's going to hurt a little bit, and it's nice and soft. Then you can, when you come back later, you can be like, oh, it still feels soft. And hemodynamics. The patient, this patient, for example, hemodynamically stable. His pain is well controlled. They held the metformin for an angiogram, which was done, and one of your assessments, part of your S and your pause is, all right, so what's the plan? When are we going to restart that? Usually it's 48 hours after you give someone a contrast load, you give them fluids, and you manage their glucose 40, and then you can start the metformin 48 hours after that. Pain control, usually post-op, you have an IV regimen, and hopefully in the morning you can convert them to a PO, get their diet going, make sure they're not taking pills on an empty stomach. And then hemodynamics, obviously, a lot of patients will have A-lines. I'm okay if you take an A-line out if, you always work at night, so you often I call you and you say, oh yeah, he looks great, I'm gonna take the A-line out. And I'm like, totally fine with it. The only time the A-line is kind of critical is during the operation for getting frequent ACTs, so I know I'm heparinizing the patient appropriately, and for their hemodynamics when I clamp and unclamp the vessels. But if they make it if they do okay out of the PACU and your status, there's not that much bleeding, things have went well, wasn't too difficult a case, I'm okay with you seeing that A-line when if you're not sure, leave it in. That's one thing. I mean, for you guys who are new, if you're not sure, leave it in. And this doesn't apply to carotids. So a carotid can look gorgeous, perfect, but that A-line stays in until the morning, until they're rounded on the next morning. This applies just to peripherals. So don't get that confused. I mean, carotids can look perfect and gorgeous, but the pressures do this, their heart rate does this, just because their carotid sinus, the carotid body has been manipulated so much from surgery. But for my peripheral arterial disease patients, if you want to check to say, hey, Mark or whoever's around, like, these guys have been rock stable and he doesn't have any more blood draws I need, so I'm gonna take the A-line out. I think that's an appropriate thing. It might be surgeon specific too, so don't just get me in trouble with Waller because they'll say, oh yeah, Peeran said we can take them out. I don't want the keys. Oh, I missed the keys. Oh. All right, so case 1. Everything's fine. You got your information. You do your vascular assessment. You looked at the wounds halfway through your day, and they look okay. The Peeran is working and sucking appropriately. He still continues to feel stable. His pain is fine. He's doing fine. He's examined. Is neurologically intact. He says, my foot feels fine. You can't feel a dorsalis pedis, but you can get one on the Doppler, and you have trouble finding the Doppler for the PT. So so that's something new to you. So when you have that, what are your thoughts? I don't know all your names, but what's your name?
Mine?
Yeah.
Hannah.
Hannah. What's your thoughts when you're in the middle of the day and you see, okay, well I got something that was palpable, now it's not.
Well, it's a change in status, so I want to let the surgeon know.
Yep, you let the surgeon know, let the PA know. But what do you think might have happened to this guy? Looking at the stem and the history.
He could have thrown a claw.
Could have thrown a clot, which, I mean, if you had an AFib history, you're thinking, okay, so you must have, when you say someone throws a clot, we kind of assume it's from the heart, because that's the most common source. All these patients are very sick, so throwing a clot is definitely right on there. But for this guy, like, what do you think, could have happened, for this particular patient? You can phone a friend too, if you want. What's your name?
Nicole.
Nicole. What could have happened with this guy?
Maybe they got recruited.
Yeah, that's the thing. That's the thing that I want to know. the bypass occluded, the one we just put in, which can happen because of technical reasons, because if outflow is not good, all these vessels are crunchy. If you have an acute change like that, the first thing is, hey, maybe the bypass occluded. Let your PA know, let the surgeon know. There's ways of assessing whether the bypass is occluded. The easiest way is to send them down for an ultrasound and see, okay, there's flow in your bypass. Oh, there's no flow, there's a thrombus there. So that's the first thing. And the next question that you have, let's say you have a PA that you're not so, that's maybe you don't, I don't know. Let's just say, you know what I'm talking about. You know what I'm talking about. Both, all you guys. Hope there's not another one. But let's say you're just questioning what's been given to you. You should say, hey, should I start a heparin drip? Let's get the patient to ultrasound. Let's let the surgeon know. So you can push the patient's care along. And that's what's great about the IVCU is that they're really, really good at that, in that they push the patient's care right along and they don't let things slide, which I think rarer and rarer in the hospital, but the IVCU has always been a reliable source of people advancing patients' care and moving things along expeditiously to get patients good results or solve their problems. So this guy, so it turns out that, this is not a real story, but the patient's bypass goes down. Okay, so you call the surgeon. How do the wounds look? Wounds look fine, there's no hematoma. Should you start them on a heparin drip? For my patient, depending on them, but for this patient, who was an elective femibulb bypass for claudication, I might say, you know what, it's okay. We'll readdress it in the morning. I can talk to them about reoperating. Or if it goes down, it is even a viable option to say, well, you were claudicating, meaning you were walking, but you just couldn't walk very far, and you give them the option, hey, do you want me to reopen this? Then they might say, no, I don't want to, or they say, yeah, go ahead. The other problem to worry about with this is if you do occlude your bypass, now you have a fresh clot in a tube in your leg. That clot, some of that clot can break off and go to your tibials. That's a big problem because you go from palpable and biphasic Doppler to nothing because you've occluded your popliteal or you've occluded your distal tibial. And then you really have to do something at that point. The surgeon has to do something at that point. But this is a rare occurrence, but it happens. And the patients that it happens to, you see the PAs or you see the surgeon rounding and they say, oh wow, that was a tough bypass, those vessels were really bad, we'll see how he does. Or if it's like, oh no, I don't know issues technically, I think it was okay, so then you're less suspicious that it might go down. But that's exactly the case here. The patient's bypass went down.
So if that happened, would you prefer us to keep the patient on bed rest and NPO at that point until we get?
I think that would be safe.
Okay.
You just call me and I'll tell you, just keep me NPO after midnight, and we'll do it in the morning.
Okay.
Tell the patient, or I'll either tell the patient or I'll. Hold on a second.
Yep.
Okay, we gotta get through this because I gotta meet the boss. All right. So, 73-year-old male with hypertension, uncontrolled diabetes, coronary artery disease, three vessel CABG, 2011, recent stents for right coronary artery, colon cancer history, and a current smoker. He's getting a fem below knee, BKs below knee bypass for critical limb. He has a toe ulcer that's blackish, and he has a 7-hour operation because you had to do the femoral endart, you had to harvest the vein, you had to do the fempop bypass. Your pause assessment is we got a biphasic DP and biphasic PT on Doppler. He's neurologically intact. His sensory is deficient, but he says he hasn't felt his toe in years because of diabetes, but he does have full motor function of his toes. He got a 325 milligram of aspirin in the PACU, no heparin drip. Wounds, got a Peeran in the groin. He's got a pico below the knee on the medial aspect, so the inner calf. Hemodynamically stable, mildly tachy to the 110s. Beta blocker has been held for a soft BP. So in your mind, when you see this patient, the first things on your mind is, okay, you got a lot of coronary artery history, and he's had recent stents, so he's a current smoker. And this guy is a guy, when he has issues, it could be a cardiac event. He gets shortness of breath. This could be a cardiac issue. So who's next? I forgot your name. I bet you. Caitlin, right?
Mhm.
Okay. So at around 10 o'clock, this guy's eating his dinner, he's doing okay. You go and assess him. He's got great signals in his feet, the same that you got at Sino. He's moving it. Provinas look okay, they're suctioning well, but he has this vague nausea and epigastric kind of like, he's kind of belching his food, and just doesn't feel right in his epigastric, kind of nauseated, and he vomits later. What are your thoughts? I mean, I didn't operate on his stomach. I operated on it, and he was eating before. Like he had his. You work nights or days?
Nights.
You work nights. So he had his supper, but then he wanted a snack later at midnight, and then all of a sudden he has epigastric queasiness, and he vomits. And his tachy is still 95. Blood pressure's, was hell. His blood pressure was 120, and they called a PA. A PA said, "Yeah, hold this beta blocker." So, what do you think might be happening to this guy?
Then he could have a bleed, like a gastric bleed, but that's not really related to it.
Well, he had a bleed. I mean, he's going to bleed from his leg. He's going like
Yeah.
hematoma. And, checking H&H. I think that's a post-op vascular patient. Bleeding is definitely should be high in the differential. But for this guy, with his history, his uncontrolled diabetes, his current smoking.
It could be like manifesting like cardiac event.
Yep. That's the highest thing in that scenario. You guys have heard of silent MIs? Uncontrolled diabetics. Sometimes they don't manifest with, I have subcervical chest pain that's radiating to my left arm, so I'm having a heart attack. They don't read the textbook, and they manifest with weird ways. Epigastric discomfort, heartburn, and someone like this, you gotta be like, okay, this guy's still smoking a pack, cabbage, recent stents, diabetes is way off the chart. Okay, so this is probably a coronary event. So what would you do if you're saying, he's getting a little sweaty, little beads of sweat in his forehead, he's tachy to like 95, and he's got this nausea. So you're thinking, okay, how would you do next?
Like vitals and EKG.
Yep.
Provider now.
Perfect. You get your vitals, you get your EKG, let your PA know, let maybe Peter's around, let him know. Any lab values you want to get?
Or troponin.
Yep, setting troponins. And I would check, if you're going to work somebody up for a problem, I would check a CBC and electrolytes too. Just because you're sticking the guy for blood, get all the information. Very rarely could it be electrolyte deficiency. So so that's exactly the correct assessment for this patient. Your troponins come back positive. There is some inversion of the T waves in lead 3. PA's made aware, and I'm made aware, and we call Peter or Jeff to assess. And the one important thing is just keep the beta blockers going. So when you get a patient, cardiac patient like this, and he has a peripheral surgery, just say, hey, let's, unless he's really soft, then you gotta ask yourself, why is his blood pressure this soft? You gotta really consider that. I mean, the American College of Surgeons recommends continuation of beta blockers and aspirin, if tolerable, for any procedure. So interrupting the beta blocker is not a good idea, and interrupting aspirin or Plavix is not a good idea, unless you have to. I mean, some of the general surgeons, they have to, because they'll bleed into their abdomen. It's not the same. Vascular surgery and general surgery are the same with regards to controlling bleeding. So that's a good assessment there, Caitlin. So this last one, 70-year-old male with AFib, hypertension, stroke, PAD. He walks 2 miles per day. He stops his Coumadin for a colonoscopy, but it wasn't restarted yet. He presented to our ER with acute limb ischemia. All of a sudden, his foot was paining. He had numbness and tingling. Felt kind of cool. Went to the ED. Gets admitted, assessed by our PA during the day because the surgeon's in the OR. Gets admitted to your floor. Eventually goes to the OR. Has a thrombectomy the femoral and profunda femoris with a patch, and they remove, some clot. Remove some clot, and you estimate the ischemia time to be about 8 hours. No angiograms were done. So your pause assessment, you got faintly palpable dorsalis pedis, biphasic on posterior on Doppler, neurologically intact, sensory intact. So on a heparin drip, the PTT of 80, the wounds look great. There's a provena and it's soft around it. Stable blood pressure is controlled. About 2 hours into your assessment, the patient calls and complains of real significant severe pain on the front part of their shin and a little paresthesias in the first web space of their first and second toes. This is a hard one. What's your name? I'm sorry.
Erin.
I'd ask you. You should know. Erin?
Yes.
Are you fairly new?
Yes.
Okay. What do you think is going on? You got your assessment here. Obviously this guy, history says, stop the Coumadin, probably through a clot from AFib.
Mm-hmm.
Usually you gotta restart the Coumadin, but sometimes the patients forget to, the providers forget to restart it. You threw a clot, ischemia of 8 hours. I mean, his leg has been pulled for 8 hours until he got revased. Heparin looks okay. 80, you do a PTT, it's 80. Wounds look okay. Blood pressure, everything else looks okay. But he's got this new pain right in the anterior part of his shin. And he's got some paresthesias, numbness tingling in the web space of the first 2 digits of the foot. So what do you think? He also says he feels a little swollen in the leg.
Doubt it, but he could have another clot.
He could, he absolutely could.
Yeah.
Patients who have clots, usually they form in the atrium and they just get ejected, and you could throw another clot. But you got palpable pulses. You think, oh, these pulses are the same. They feel palpable, his foot's warm, he's neurologically intact. Everything looks okay, except for those paresthesias in the first 2 digits and the swelling he feels in his leg. This is a tough one.
I mean, it wouldn't be like, I guess it'd be, could it be like reperfusion, feeling reperfusion issues?
It's part of that process. Reperfusion is part of the problem. But, there's a specific entity here. Did you know?
No, I was gonna say the same thing.
And, reperfusion is part of this process, but there's a specific syndrome that this is associated with.
Is it?
You want to give it a shot?
I'm thinking like compartment syndrome.
Yeah,
something
perfect.
similar.
Perfect. So this is the comparison. The big thing, and if I got sent out, I'd be, well, why the hell didn't you do fasciotomies? Because the reason we do fasciotomies is because you're ischemic for so long, and then you reperfuse. The reperfusion causes swelling, and the compartment is a finite space, the fascia, and the muscle swells so much that it actually can compress the vessels, compress the nerves, and cause severe pain. If you're suspecting someone with compartment syndrome and you examine them, you press on their the anterior tibialis muscle or their calf, they'll jump off the bed. That's how painful it will be. If you could just run your hand on the anterior aspect of their shin, they'll scream in pain. So that's a compartment syndrome, and that's especially with a patient that you get. Well, that's a good question to ask when you get a patient at sign. Well, how long have they been ischemic? Oh, this guy was at home. He was found down. Do they do fasciotomies? I hope they did, because his leg is going to swell and his compartments are going to cause a problem. He'll have a compartment syndrome. No, good job. That was a tough one. All right, I gotta run soon, but I'll take a few questions. Just anything under the sun, anything about our service, anything about the IVCU. Anybody? There's no such thing as dumb questions, so please, if you have anything to ask, please do ask.
So when you have a provena in the groin, there's staples under?
Staples or nylon sutures.
Okay, but then if it was like on the thigh or lower, if it's the pico, there's nothing, right? Just Dermabond?
No, it can be staples under there too. You
Okay.
can have staples or sutures under both of them. The picos stays on for like 3-4 days. The provena can stay on for a few days longer. I like the Peeran in the groin because it has a better sucking capacity. I think it can hold like 30 cc's.
Mhm.
The Pico gets saturated in like 5, you know, it's just a pad. The Peeran has actually a chamber that can, and you've seen them, right? But they actually can, they have a better capacity to hold fluid.
And if it comes undone or becomes saturated, we're allowed to replace.
The Peeran?
Yep.
If you feel comfortable doing it.
Okay.
You know how to do it, but if you don't, I wouldn't, you know, like
Right.
call somebody to do it or ask. And you can always take it off, take a look at the wound, like, okay, he's not leaking or bleeding out from it. Let me put a 4x4 and a tegaderm and let the PAs deal with it in the morning. That's totally fine. But the biggest thing is, why is it feeling? I mean, is fluid pouring out of that thing?
Right.
Or is it just a bad technical seal? Because sometimes you got with bigger patients, you have to put the plastic in the folds to get the thing to seal. It has to be airtight. So sometimes it's not a good technical placement and it just fails because the patient moves and the seal is lost. Or it could just be filling up and like it's over capacity. That's a bigger problem. Like, okay, is he having a lymph leak? Is he bleeding? You know. Any other questions? Do you guys have any questions? The seniors? The freshmen have any questions? Seniors have any questions? But, all right. What other things do you want to know about? What other of our patients? We did a carotid series. We did a carotid lecture. We did an aneurysm lecture. We did a PAD lecture. Have we done do you guys deal with dialysis patients?
Yes.
You do with fistula patients.
Mhm.
Well, you decide maybe what other topics you think people know about, and if it wants to be more specific to certain nursing things, like we can do a talk on even just wound dressings. What's a Provena vac? What's a KCI vac? What's a Pico vac?
Mhm.
What's you know if that would be helpful. I don't know what like your knowledge bases with wound. Some nurses come in with a lot of wound care background, some don't. So I'm happy to do that too.
I think that'd be helpful.
Yeah. Okay, I can do that.
All right, I gotta run, but thank you guys.
Thank you.
Thank you.
Yeah.